My name is Maddie Stiers. I'm the Director of Clinical Services here at the Hope and Healing Center. If you'll forgive me, I have a bit of a cough, so I'm actually your presenter tonight as well. So I'll be introducing myself and then giving the presentation. So if I'm coughing, bear with me, I apologize. If at any point during the program you can't hear me, raise your hand, let me know. I want to make sure everyone in the back can hear as well. So I guess we'll start with, we've got a smaller crowd tonight, so I'm going to be picking out people and asking questions. They're like, oh, darn. Well, so how many of you are familiar with the Hope and Healing Center? I see some familiar faces in here, but is anyone not familiar with what we do? Yes, is it your first time here? Yes, well, welcome. We're excited to have you. We do a lot of different things here. I'll give you a brief rundown, but if you have questions afterwards, feel free to come talk to me. I have cards out on the front desk as well. You can reach out via email or give me a phone call. If you are a mental health care provider or in the health field and you'd like to be added, am I doing something wrong? No, okay. And you'd like to be added to our network of referrals, there's a form online that you can fill out, and we'll reach out to you and get in touch, see how we can partner with each other through clients and our client needs and whatnot. So I will start with our training program. So the training program that we offer here at the Hope and Healing Center is called Gateway to Hope. And what that is we have several trainers who go out into faith communities and focus on training the clergy or leaders of that faith community, as well as the lay people in that faith community, on how to identify mental illness, addiction, trauma, things along those lines. So we do kind of an overall training for the whole faith community, and then we do more specific trainings for how to implement support groups. We actually have a curriculum developed to where the support group can be peer-led, as well as we have our Renew training. So our clinicians here at the Hope and Healing Center are called mental health coaches. So we're actually training peers out in the community on how to become a peer mental health coach. The curriculum that we use here, which I'll explain in a second, was developed at a peer level. So non-mental health professionals can deliver those services. So we're going through and providing training on to people in the community, open those doors, open access to care, providing free services for people. All the trainings and whatnot that we offer are free of cost. So if you have your church or your faith community and you're like, wow, that sounds great, feel free to reach out to us. We'd be more than happy to come out and provide that training for you all. We also have our educational programs, which you are at one right now. We have split them up this year. We have our community education, our CEU programs, which are typically for mental health providers, but anyone is welcome, where you're going to get your CEU, you get a certificate at the end, so we're glad that we can offer that. We also have just community education programs that are more broad, less practical, focused on addressing issues that people in the community might be interested in ways that we can help educate on mental health, the lifespan, health disparities, things along those lines. We also have our institute, so we're the Hope and Healing Center and Institute. The Institute is several postdoctoral PhD level fellows that are here doing research on mental health and the aging lifespan, excuse me, trying to identify gaps in the services that we have around Houston and the greater Houston area, and then implementing some form of service or pinpointing the areas that have those gaps. And then hopefully we here at the Hope and Healing Center can bring on some sort of service that fills that gap. So that's been a pretty interesting process to watch. We also have the clinical services, which I'm sure is what you're all interested in. So the clinical services, we have several different things. It's been a pretty exciting last 12 months for us. Here we've brought on several different programs. We've really expanded the services that we can offer to individuals, all free of cost, which is really just kind of a blessing that we're able to do that. And we really hope to be able to continue to do that. So if you have a client or you yourself or a family member or loved one is looking for mental health care services, we're a good place to start. Someone gets calls our center. They get directed to our mental and behavioral health service line. From there, they'll have an over-the-phone assessment, determine whether some of the services that we offer will be a good fit or if we need to refer them out. The population we work with is 18 and older, more serious chronic mental illness. We see a lot of people exiting hospital stays, a lot of people who have been through treatment time and time again that's not really been working for them, so more serious cases. We don't do couples counseling, and we don't have family therapy. So those would be people that we would refer out, as well as children and adolescents. But if someone gives us a call, we will always provide them some sort of service, whether that's a referral or actually entering into our clinical programs. So they call, they have an intake assessment done over the phone. And then from there, if we say, oh yeah, this is a person perfect for the center, they're entered into one of our 2 therapy-based programs. We have our DBT program, which is standard DBT. I know some of you might have been out before to Karen Hall's programs here. She actually was pretty instrumental in training our clinical staff on implementing the DBT services that we have here, so that's been an awesome experience. So the DBT program, as well as our mental health coaching program, and that's a CBT-based program. That's actually the curriculum that the trainers use when implementing peer mental health coaches in faith communities. Yeah, more CBT-based. So depending on what the assessment says and the conversations that we have with them, we determine which would be a good fit for them. Once they've entered into one of those 2 therapy-based programs, they then have access to our supplemental services. The supplemental services are case management and telepsychiatry. The DBT, case management, and telepsychiatry are all 3 new programs that we've brought on in the last 10 months or so. So it's been a really exciting and busy year for us, but we're glad to be able to offer that. Right now, we don't have the capacity to open case management and telepsych to individuals who are not in one of our 2 therapy-based programs. That's hopefully somewhere we'll get, but right now, if they're in one of our programs, they have access to that. In the telepsychiatry, all of those are free of cost as well, and we actually have the ability now to pay for medication. So that is something that we can cover if the client needs that. There are also around 40 different support groups here at the center. Those can be accessed by anybody. Our staff facilitates about 6 or 7 of them. The rest are self-led 12-step groups or facilitated by outside organizations. We have NAMI that's been here. We have Remind, the Alzheimer's associations. We have different, right now we have a Memorial Hermann. We just started our pregnancy loss support group, so that began in March. So we've got a wide variety of support groups for individuals who are suffering, as well as caregivers or loved ones of those who are suffering. And I think that kind of covers a large portion of what we do. Like I said, if you have any questions, feel free to reach out. Those referrals that we provide for people who aren't a good fit or people who are exiting our program because they are time limited, like I said, if you'd love to be on our referral network, please reach out. We'd be more than happy to touch base with you and see, what scope you practice within and how we can be of service to each other. With that being said, I will jump into the presentation tonight. How to avoid ethical pitfalls. I have been to many ethics CEUs and presentations, and I'm sure you all have as well. This is a requirement by most of our licensing boards. We're not going to touch base so much today on kind of the standard things that we hear about. I'll review documentation a little bit. I'm not going to go too much into relationships and boundaries with clients. Those are things that I see covered pretty frequently. So we're really going to jump into subpoenas, which I know a lot of people are really interested in, as well as, well, here, let me just put the agenda up. So we're going to talk about what ethics are. We're going to talk about what ethical misconduct is, real brief. Documentation some, confidentiality a little bit, along with subpoena compliance. I have to say I'm not a lawyer, I'm a social worker. So this program is not intended to be a direct guidance if you are subpoenaed or if you have legal issues. We always recommend that you seek legal counsel if you are subpoenaed or you have further questions. You can ask me, but I'm just not a lawyer. We're also going to talk about religion and spirituality, what that looks like ethically. How do you walk with someone through their faith journey, as well as leadership roles and responsibilities. So whether that's clinical supervision that you're providing to students or someone in their internship or LMSW phase, or if you are in a supervisory role within your organization. So we're going to talk about what that looks like and ethically what areas that we see ethical dilemmas occurring in, and then what we can do to help manage them. So ethics are a set of values and principles that govern our decision making. How we conduct ourselves, how we work with clients, how we interact with other people in the workplace. Typically, when we're talking about our licensure, it's a little bit more specific things, right? We want to be ethical when we're talking to people in our work, our colleagues and coworkers, but there are more specific areas that fall under our licensure and our laws. So our ethics are governed by our board. So I'm talking pretty general today. If I'm saying any specific things regarding ethics, I'm talking about social work. It's what falls under the social work ethics, because I'm a social worker and that's what I know. From my understanding, social work ethics and values are a little bit higher. Time frames and things like that are a little bit longer than LPCs and psychologists. So if you follow the social work ethics, you're most likely going to meet the requirements for your licensure as well. That may have changed, but that's, from what my understanding, that's what it is. So what is ethical misconduct? It's something that we run into constantly, right? With discharge planning, is this someone who we can exit ethically from our program? Questions that come up with boundaries, legal issues that come up. Sometimes it's pretty clear, right? We hear the whole old adage, don't ever sleep with your client. We all know that one, right? That's pretty steadfast. But there are times when ethics can be kind of unclear, not sure what the right or wrong answer is, or maybe there's multiple options, and then which one do you do? In private practice, that's where we tend to fall into things, is uncertainty and not being clear exactly maybe what the right path is. When you're working in an organization, typically what you see is it's structural. We see people who start a new job and they're really excited about it, and then all of a sudden they're realizing that some of the policies and procedures that are in place are not as ethical as they might have wanted them to be. And how do you handle that? How do you manage that? That's a hard one. Especially if you're coming in at an entry-level position, how do you then say, okay, that's wrong, you need to fix it. I know exactly what I'm talking about, right? We need to adjust this. And no one wants to be the kind of red flag raiser, but especially if it's your new job. But ethical misconduct can be intended or unintended, right? Sometimes things just happen, and afterwards you go, oh, maybe I shouldn't have done that. Maybe, okay, I'll make note of that and correct it in the future. But sometimes, you have egregious errors that we see. Think of Enron. We're not just talking in mental health or in health field. There's ethic issues that we see happening all around us, and in politics. There's a lot of things coming up in politics about that. We're not going to talk politics tonight, but I'm sure we all could. But yeah, the reason that ethical misconduct or errors typically occur is that we don't know the standard to which we should be providing care. We don't know what our licensure requires. We don't know our state laws. If you were subpoenaed legally in Texas, what is the first thing you're supposed to do? Would any of you know? Raise your hand if you know. Yeah, and it's a hard thing to know, and we're all kind of terrified of it, but really, knowledge is power, right? So as soon as we understand what our role and responsibility is and how we can handle it in an ethical manner, we really take power over that fear that we kind of see around ethics. Like, oh, I don't want to do anything unethical. Of course we don't. But being aware and taking power over what you're doing is really going to help prevent you or your organization from doing anything unethical, and it's really going to give you more peace of mind when working with individuals. excuse me. So as I mentioned, we see two types of ethical dilemmas. These are pretty broad generalizations: personal and organizational. Personal, what we often see is a pretty common one is a blind spot. We see that happening with individuals who are in private practice, or who may work independently. Especially after years and years of being in the field and having pretty good understanding of what you're doing and the clients that you're working with, we kind of get on this roller coaster, this train of like, oh, I know what's next, I know what's next, I know what's next. We develop blind spots. We don't have anybody checking us. We don't have a check and balance system. So we miss things. And it's typically, for an individual, you miss the same thing over and over again. It's a blind spot. You don't even realize you're missing it. And no one's there to check you. So solution to that is consultation, right? Even past supervision phase, if you're not required supervision, having consultation, having a group of professionals or a team that you can touch base with if you're working in private practice is really important, because they're going to be that check and balance system. They're going to be the sounding board for you to bounce ideas off of. I just actually learned today that, do we have any psychoanalysts in here? No, okay. Yeah, I just learned today that if you are a psychoanalyst, you have to be in psychoanalysis until you're dismissed from that. So you have to be actually in it as well. But supervision continues for almost indefinitely as well. So there's a point where you can be exited from it, but they require that you kind of present in front of this consultation group that you have. So and you're not presenting how great you are. Excuse me, you're not coming in and going, this is what I did and I'm awesome and these are the clients that I've helped. You're coming in and saying, okay, this is where I messed up. This is what happened. And then people review it, like 200, 300 people throughout the country in your consultation group can review it and provide feedback. So you're getting a bunch of different eyes on it. You're getting, oh, I did that too. I've done that before. So it's kind of normalizing it. We can't be perfect, and having ethical issues pop up and not knowing what to do, or maybe handling them incorrectly one or two times is bound to happen. But I just thought that was kind of interesting that as a social worker, past working towards your LCSW license, you're not required supervision. They really strongly emphasize consultation, continued consultation. The other thing that we see is the confirmation bias. So that's narrowed lens. It's a little different than what I previously mentioned, in that someone comes in and tells you something that you've heard 1,000 times, and you just go, okay, this is what I'm going to do, this is the treatment, this is how I'm going to deliver it, X, Y, and Z. We typically see confirmation bias in treatment. We've decided that they have this diagnosis because we've heard someone who had this diagnosis say something similar before. So our lens is narrowed, and we've decided that we're pretty sure this is what it is, so we don't see the other things that are happening around that person. We're not looking at it from a systems perspective. Maybe we're not touching base with family or friends that they've said, hey, reach out to them, they'll have some good insight into what's been going on with me, because we're working towards confirming what we've originally identified as, we decided as their treatment or their diagnosis. And that can be an issue, right? Because you could be doing harm to that client if you've not gathered all of the information. We really want to make sure that we're providing ethical care. Maybe they need to be in a different sort of treatment that you don't provide, and you've missed that because we're working on that confirmation bias. So what's a good solution for that? Consultation. It's a running theme of the night. If you're working in private practice, having a consultation team or having friends who are in the field, things that you can bounce ideas and questions off of. If you're working in an organization like this, I know here, our clinical team, we have a clinical staffing every Thursday. So that's something that we're constantly checking in with. And it's a constant thing, where, oh, I'm having this struggle, or this is something that's come up. What are y'all's suggestions? Kind of opening it to the group and saying, like, what is your idea? Maybe you have a different or better idea than I do. Helps kind of guide treatment in a more ethical manner. Diagnosing to access services. This isn't something you hear about as often, but it is something that happens. This is one of those kind of tricky ones. You have a client who doesn't meet the criteria for X, Y, and Z, but they have to have this criteria, or they have to live in this zip code, or they have to meet some sort of criteria to be able to access additional services. We see people fudging that a little bit, right? They'll say, oh, they're just a few, bullet points off from actually hitting the DSM. We'll just give it to them because they need it, And they do, and that's still fraud. It's if you're going through insurance, especially, it's you're lying on medical documents. This is a conversation that we could get into, but I won't fall down the rabbit hole of that so much. This is happening because we have a broken health system. We have people who need care who can't access care. We have a limited amount of services, a limited amount of space, and an overwhelming amount of people that need access to those services. The other one that we see kind of happening here is we don't ever want to tell clients who need to be hospitalized but that are not suicidal to go to the hospital and tell the intake person that they are suicidal. But we see that happening a lot. It's ethically not something we should be doing under our licensure, but we do see it happening, right? People who need care but don't have access to it have to kind of fudge a little bit. So it's kind of that. Would you steal a loaf of bread to feed your starving family? Yeah.
I just had a question. So diagnosing to access services. Do you know, because this is kind of, I've been debating this with a few people. So somebody who has marital therapy covered under their insurance, and you can't use a Z code to get paid, but you can bill under the CPT code for marital. What do you do? Where I'm working, they will not allow us to do marital, even if they have that as part of their benefits.
So is it not a service that's provided at your agency?
Well, it was until, the insurance company won't pay on a Z code,
Mm-hmm.
right? And so kind of what I always kind of look at is the anxiety, the stress of, so I usually do it under an adjustment disorder
Mhm.
with anxiety, but our owner believes that is insurance fraud, because it should be a Z code. What are your thoughts?
That's one of those hard, sticky
Okay.
situations, right? And that's when it comes down to having conversations. Because what my answer is going to be my ethical belief of what should be happening, which might be different than yours, which is different than your boss's.
But wouldn't there be, if we're looking at like fraud, shouldn't there be a hard answer for that? Wouldn't it move? Yeah, wouldn't it move out of like an ethical dilemma to something that would be actually have an
Yeah.
answer?
So the question, I'm going to repeat the question. The question is, someone comes in, is having marital issues, can we bill it under adjustment disorder? Because that's kind of what we're seeing, or because insurance doesn't accept Z codes, how do we handle that? That's a hard question, and this is what we see constantly happening. And it's not, you had mentioned that you had been bouncing this around with several people, which is exactly what you need to be doing. It's
Insurance companies won't pay on
so
Z codes.
and from my understanding, it becomes fraud when you don't have justification to back it up. When you don't have any reason to say, like, yes, this is actually, there is a reason why I provided that diagnosis. That's what I would say. Look at it from, one, an organizational standpoint. Does the organization actually provide that service? And two, is there justification for why I'm coding it the way that I'm coding it? And then running that through with the team members or your supervisors and things like that. Because if something were to come back, legal action, you want to have documentation to back up. This is why I did it. This is my like they meet this criteria, this X, Y, and Z. So it's really documentation. Do you have the documentation? Do you have the evidence to support the diagnosis that you're giving? Does that kind of help? It's hard, soft answer, but.
Yeah, I was just really curious because this has just become an issue in the last 2 weeks at where I work. And now the decision's been made that even if it's a covered benefit, we don't do at all unless they pay out of pocket.
And so then that's where we see the organizational ethic structure coming in, right? We have our own beliefs as personal individuals, what we would do, what we might make decisions on, but the policies and protocol and procedures that are set in place in an organization might vary a little bit. Now, whether that's egregious can vary as well. It's a spectrum, right? Is it like, oh, we're just going to lie on everything so we can get as much money from insurance as possible, or is it a protocol set in place to kind of manage the population and the services that are being offered? So it's a hard.
Thank you.
Sure.
Taking the time to address
Yeah. Where was I? Okay. Practicing beyond experience and expertise. That's malpractice. We don't want to be causing harm to anybody. Obviously, if you are not trained in DBT or trained in ACT therapy, you wouldn't want to put that on Psychology Today. If you don't have any experience working with children and adolescents, it's up to you. It is your responsibility to go out and receive training and gain training and ask people and receive consultation about the clients that you might start bringing on. But yeah, practicing beyond our expertise is another one that we don't want to be doing. Organizational. Pressure to conform or please, especially if you're just starting. You come in to an organization and you think it's great, and then you start to see the little flaws. You start to see the little things that are happening that kind of raises little flags on your end. Sometimes that's overlooked because maybe we're new and we don't want to be that new person that comes in and says, I know exactly what needs to be changed. I'm the best. I have all of the answers. But we also don't want to be that person who just turns a blind eye to it. So how do you have that conversation? I've heard several stories of how people have addressed this, right? Some people go in guns blazing, and they're just like, this is wrong. And that's never met well. There's reasons why things are in place, and there might be something behind that you're not seeing, that you're not understanding. So really going in and asking questions and being able to come at it from a gentle point of view and saying, it makes me think that if we're doing X, Y, and Z, how is that benefiting the client, or how is that following laws, or what it is, how are we actually doing what we're saying that we're doing? But asking those softer questions, get some answers and get some information that might not be readily available to someone coming in at a ground level position. Okay, I'll get to that later. But motivated blindness is another one. We see that in big organizations. We see that with people who are dealing with millions and billions of dollars. When my interest is going to benefit from making a decision that may be kind of unethical, we just go, well, it's not that unethical because we're still delivering a service. It just might not be the same service that we're delivering. So we kind of make little excuses. This is where you see little excuses that are being made on these big decisions that are really going to benefit that individual and not so much be an ethical decision. Kind of trails into the outcomes that we especially here at a nonprofit. So outcomes measures. We collect outcomes measures and data on everyone that comes through this door, so we can provide that information to our funders so we can continue to receive funding. Now, if I just doubled all those numbers, then it makes us look like we're doing more, or we're moving beyond the scope of what we're actually doing. That's clearly unethical. But is manipulating the numbers to look better in your favor, even though you've not actually changed the numbers, you're just maybe showing what's the best numbers? Is that unethical? That's where this question comes in. And if there's oftentimes we get a feeling in the pit of our stomach that says, ugh, I'm not comfortable with that. That's when you really need to take a step back and look at the situation and say, am I acting ethically? Would I kind of tisk on someone else if they told me they were doing this? And am I making excuses for why this is happening? Excuse me. So structural, lack of ethical supervision. We see that oftentimes in hospitals, when there's a huge number of staff, there's patients coming in and out, turnover with clients is very high, and things kind of fall to the wayside. It's hard when you don't have a supervisor following everyone around, and you've got very sick individuals. One way to address this is transparency. Explaining to your staff, asking questions to your supervisor, why are we doing this? What's the reason for this switch? It's not being nosy, it's not asking because you're trying to take over their job or anything. It helps your team to understand what's happening so they feel more confident in what they're doing and their ability to deliver the services and make decisions feeling secured in what they're doing. So where do we go wrong? How can we better ourselves? So, excuse me, we talked a little bit about personal ethical dilemmas, things that come up, and structural. Now we're going to break down a little bit more detailed into what specific things we see happening often. Relationships and boundaries, conflict of interest. You've just got this, you're just moving into a new house, and the landlord's like, hey, I'll give you a deal if you work with my sick kid, right? We'll cut you some slack. Okay, that might seem great, and you practice within the scope of what that child is struggling with anyways. But then what happens when the dad's no longer satisfied with the service that you're delivering? Or you've completed the scope of what you can do and they need to move elsewhere. Now you're in a sticky situation, right? If the dad's upset, you have to terminate. You now are signed into this lease and you've got this landlord who may understand, but also may not. Right? So if he does understand, it might not seem like an ethical issue because it kind of smoothed out, there wasn't an issue, no problem, move forward. But if it does become an issue, what do you do? How do you get yourself out of that? Because that's a hard place to be in. I've never actually heard of that happening, but I imagine that would be hard. Dual relationships. We all know what that is. One example, our family and friends, right? Obviously we don't want to be seeing our own family and friends. Providing services in that sense is just not ethical because we have so much more information than what we could actually practice with. However, we do see dual relationships, things along those lines happening within EAP, employee assistant programs. There's a lot of consultation or contract teams that will go into businesses and provide kind of one time, several months of EAP. Maybe after a trauma, a school shooting. An organization might come in and offer services to these children, or the teachers, right? And it's bound to come up additional issues beyond what that one issue they might be there for. Susie's talking about Sally, and work issues come up, and you're seeing Susie and Sally and John and Joe, and so now you have all this additional information. Is that ethical? Would you do that in your own practice if it was a private practice, or if you had the ability to say, oh, I'm going to refer you, right? But it is ethical when it's set up in a structure like that. This is what's meant to be. This is told during consent. I'm going to be working with colleagues. Obviously, everything we talk about is confidential, but they're informed. The client is informed and understands the process of the services that are being delivered, which is really the important aspect of that. And implications of countertransference. Countertransference isn't something that we talk much about past school. Maybe you do. Maybe you have a great consultation group that does talk about it, or maybe you have a staffing group that does talk about it. That's awesome. But we often hear about transference. The client's just transferring onto you. But we don't talk about our own counter-transference. Is it something that we should just go, hey, counter-transference, identify, and then kind of move past it neutrally? Or is it something that is warranted exploration, or exploration, excuse me? Is it something that we should be kind of diving deeper into? Is it going to affect the client's treatment? Some of it might be kind of brief, like, oh, they kind of look like someone I went to middle school with. But it's like, oh, they remind me of my brother, right? So there might be some instances where you explore deeper and some instances where it's not as necessary. Within supervision, talking about countertransference is really important. Increasing conversation around countertransference within supervision while individuals are in school, as well as their clinical supervision afterwards, and talking more about it within the education that they are gaining in their program. Those are some ways that we can really ensure that this issue is being dealt with appropriately, because right now it's kind of briefed over. And then one of the cues that we can always kind of tell that maybe countertransference is happening is if we are oversharing with our clients. What's the reason that you're telling that client that personal thing about you? Is it kind of we're getting to know them and you're, my name's Maddie, I'm from San Antonio, I have 2 cats, I love my cats, there are pictures of them in my office. Kind of things you'd share with almost anybody. Or are you disclosing that at some point you had an eating disorder? Is the reason you're disclosing that because they're having a hard time coming to terms with their eating disorder, and you think that the rapport that you have and that information might lead them on their path to healing? Or is it totally random and it has nothing to do with what they're talking about? There's a new show, and I think it just got canceled, which I'm kind of bummed about. I want to say it's on NBC. It's called Shrink. Has anyone seen it? It's a funny show. I thought about running the trailer here tonight, but it's a little R-rated, so you'll have to go home and watch it on your own. But a lot of the kind of comical things that we think about sleeping with clients, like they're telling you about how, X, Y, and Z is going on at work, and you're just going, I know, work is just so hard. I have all these clients. Like, there's one outside waiting right now. And I'm just like, oh, I see you. Stop knocking. Stop ringing the bell. So he does things like that, the guy on the show. And, it's kind of comical. But yeah, is there a reason? So he's very good at oversharing. And he talks about this debt that he's in and all of this stuff. And the clients at some point start consoling him. They're like, are you okay? And they come in and they're like, how is everything going with, X, Y, and Z that you got going on? So that's when your clients start to worry about you. That's a big sign that you're oversharing. Excuse me. And then status and power. As much as we do our best to work with clients from a partnership level, to really meet them where they're at and not hold this power over them, they're coming to you for a reason. They're looking for help. They're being extremely vulnerable or trying to be extremely vulnerable and asking for help and working with you. So we do hold power. And it's important that we're aware of that. So when we say things or when we make comments to them or when we're making decisions about their treatment plan, we're aware of that and we're working to not hold dominance over them based on our position to an extreme degree, right? Okay, termination. So I hear a lot of my clients coming in very upset. They felt like they were, this is probably a term that you guys have heard, they've been broken up with or they've been dumped. Has anyone heard that? I have clients come in and say, oh, my last therapist dumped me. They broke up with me. And I'm like, what happened? And there's a sense of abandonment. They feel like they were just like, you're too difficult, get out of here. And that's not ever what we want when we're terminating, or I say exiting, I like the word exiting better, it sounds less hard. We say terminating, and I think of the Terminator, and it just goes a whole other way. So there are some reasons that we can ethically terminate, right? And this is another one of those lines that's kind of hard to determine, and you have to kind of go with your gut, seek consultation. And then there are some things that we just obviously would not terminate for. So when you can terminate ethically, is the client no longer needs it. This one we actually see going the other way. We see providers continuing to work with people way past the point of where termination should have happened. It becomes more of a chit chat. They're kind of friends, just checking in, seeing what's going on, as opposed to saying, hey, the issues that you came in here to work with me on, we've kind of managed those. I'm thinking maybe we cut it down to maybe once a month, and then slowly terminating and saying, but if something comes up at work again, I'm here. You can always reach back out. So when issues do present themselves, they have that safe place to come into. But the boundary of therapist-client or provider-client isn't being breached. It's not being waived in that client's mind. They have a firm understanding of what your role is versus what their role is in that situation. Another reason that you can terminate ethically is if they will no longer benefit from services, if they will be harmed, or if they are failing to participate in the program, right? Obviously, if you're working with someone and you realize that, you're dating their dad and they have all these dad issues, that might harm them. It's a good reason to terminate. If they're not participating in the program, this one has to be identified at intake, during consent, through the development of your treatment plan. You have to say, this is what we're going to be doing, this is what we're going to be working on. It might change. When it changes, I'll touch base with you, I'll let you know. We'll have a conversation about it. But just deciding, okay, well, they're not doing what I want them to do. I'm going to end working with them because they're difficult, is not ethical. Clients have a right to self-determination, whether we agree with that decision or not. Now, if they're not following the program, that's different, right? So if part of the program is that, so for example, our DBT program, clients cannot come to our DBT services, or any of our services actually, presenting as if they are under the influence of a substance. Now, I can't actually say yes or no whether they are under the influence, because I don't have my drug kit on me. But I can say, at the beginning of the program, we tell them that. We'll ask you to leave class. We'll end session if you show up, and I'm concerned that you are under the influence of a substance. So that's really terminating that one session or that one class, but if it continues to happen, it's a conversation to be had, right? They're not following the program rules. Maybe they're not coming. You're not ethically delivering the service that you said that you were going to deliver, so do you keep taking their money because they don't cancel? So things like that come up. Previously specified time is reached. Our services are time limited here. Our coaching program is between 8 to 10 months. We work with people on what we call short-term goals that we're trying to help them reach within a year. So they may not have reached that goal to completion when they're exiting our program, but we talk about termination or ending our services the first time that we see that person. So it's really important to be talking about termination from the get-go. Abandonment doesn't come up as strongly if you're having that conversation and you're reinforcing that it's not you abandoning them, it's part of the program. They have an understanding and an idea of what to expect and know there's an end date, so it doesn't kind of just smack them in the face. Non-payment of fees. You can ethically terminate clients if they're not paying you, if that's something that your practice does, with one caveat. If they're in crisis, it is your responsibility to get them to an organization or a provider or somewhere that they can continue services. Typically that's providing referrals. You can go above and beyond, call that place if they give you a release of information, get them set up. But in the end, if the client does decide, no, I'm not going to receive services elsewhere, that's their right to self-determination. But it is your responsibility to make sure that you've done everything that you can to make sure that client is not ending services and not moving into something continued if they are in crisis. Obviously, if someone's threatening you your staff, other members of a group or a program, depending on the setting. If you're in a hospital, someone's threatening another person, they have different things that they do. But if your client comes in and sits down and starts threatening you, you have the right to ethically terminate with that person, because your safety comes before the client's safety. So it's your safety, client right to self-determination. And your staff safety is up there with yours as well. So this quote that I have up here, it says, "I'm not going to continue to see you if you don't do X, Y, and Z." Let's go to an AA meeting. Raise your hand if you would say that that is an ethical. If you believe it is an ethical reason to terminate because you've said that your client needs to go to AA and they're not going to AA. Raise your hand if you think it's ethical. Okay, so no one raised their hand. I'm assuming you all think it's unethical.
Well, I would say maybe in a private practice setting would be different than maybe a substance abuse treatment center. Like, I've worked in different settings have different rules and expectations of the program. And so if someone's specifically receiving substance abuse services, maybe that's a condition of them continuing treatment. But in a private practice setting, that's something that could be encouraged, recommended, but I see more of a self-determination in that kind of stuff.
Bingo, that's exactly right. So she said it depends on where the service is happening. If you're in an organization, that's part of a requirement, which was probably told to them at the beginning of signing on for these services, then yes, that might be an ethical reason to terminate. But in a private practice, or if you're working in a group practice and the client just doesn't want to go, but you think it'd be great for them, that's more client self-determination, right? So we see ethics coming up, and it might seem super clear, but it really depends on the broader view, kind of going 30,000 feet above the air and looking down, what's happening around you and around that client. Are there other factors that need to be taken into consideration? That's why the question that you asked me earlier about insurance and diagnosing and whatnot, it can be tricky. It can be really hard. But documentation and having reason and having informed the client of what's going on and what they can expect is really vital in being able to make ethical decisions in hard instances. Closing your practice. A lot of people don't think about it. At some point, we all retire, right? So what do you do when you're closing your practice? Is anyone here a social worker? Do you know what our licensing board requires time frame for if we are terminating or exiting a client? How far in advance we have to give them notice? It's 4 weeks. Mm-hmm. So technically, I could tell a client, in 4 weeks, we're done, right? But is that what's going to be best for that client? Maybe, but maybe if I've been working with someone for 4 years and I've decided that I'm going to retire, which that means they can't then come back to me to receive services later, maybe I should extend it out a little past 4 weeks, right? Maybe I should do 3 months or 6 months, start preparing them, start getting them set up, building rapport with other clinicians, reaching out to other community organizations or therapists in your area, helping them develop a treatment plan, continuation of care, if that's what they like. You always want to be able to provide referrals, offer them suggestions. I think this might be a good place to go with your treatment. Being able to walk them through that process, especially if you're closing practice for good. Very, very important that you follow that. You also have to maintain your notes and documentation. You would want to maintain them for each client. Client A for the allotted amount of time. Client B that started a year later would go a year extended past that. So I would say, you do however you want, it's just the last client that started. Just hold on to all the documents until that last client has has run its round. And with adolescents, you have to wait until you have to keep documentation until they're 18, and then that timeline starts. So if you started working with a 3-year-old, you have to hold on to the documentation until they're 18, and then the time frame with which your licensure requires starts. Mm-hmm. Now, if you don't work with children or adolescents, that's not something that you have to worry about. Another thing that we see happening when individuals are closing a practice, or maybe even just switching jobs, right, is we see the boundaries, that therapeutic boundary kind of waning. It's very emotional, I would imagine. I have not retired yet, but I would imagine closing a practice that you might have had for a long time would be really emotionally, triggering for you as a practitioner. And you've built these great relationships, and you love the work that you're doing, but it's just time to retire. Maintaining that boundary and not moving in towards that friendship level with clients is really important. It can be very confusing for the client. Wait, are we going to be friends? Because you're closing. You're not going to be a therapist anymore, right? So can we go get coffee now? Your demeanor is switching more to hey, what's up, buddy? So maintaining that professional boundary that you have with them is really important. As a social worker, as a mental health care provider, I would say you should never sleep with your clients or move into friendship relationships with your clients. Social work ethics dictate that we can never, ever do that, especially if it will cause harm to the client. I'm not sure specifically on other licensures, but I know that they're, psychologists, I think it's 5 years. They say you have 5 years post-termination that you can't engage in a dual relationship, with that client. As a professional, I'm not sure why I would want to move in that way, but we do see it happening. And if you're ethical, if your licensing board dictates that you can, that's something that you can do. It's just something to be aware of. Is it really going to benefit that person, even if they're not your client any longer? And then death or serious injury. What happens if you get into a car accident and die tomorrow? What happens to your clients? I mean, 1, they've got to go somewhere. 2, that's going to be really traumatizing for them, or it could be very damaging. Would you have something in place for if that were to happen? Your family's going to be upset that you passed away. They're going to be dealing with all of that, all of the issues that are happening in your personal life and your family. So what happens to your clients? Who's going to pick up those pieces? That's where developing a professional will comes into place. It can be done through a lawyer. They can put it together pretty quick. So seek legal consultation. Again, I'm not a lawyer. This is just what my research has shown me. So within a professional will, they're going to designate a professional executor. And that person will be responsible for finding documentation. In the will, it should be listed where everything is, where the keys are, codes to things, X, Y, and Z. And then the professional executor, that's what it's called, will contact clients. You're giving them release to kind of have that conversation with someone, say, hey, I know that you were a client of so-and-so's, this is what's happened, unfortunately, getting them the referrals. Oftentimes it is another mental health care provider that is the professional executor, but I would suggest that, but your lawyer might say something different. And then they also recommend that you have a secondary professional executor. So say you set up your will tomorrow, and then in 20 years, you die unexpectedly. Well, your professional executor has passed away 4 years prior to you. What happens then? So having a secondary one, someone just having a safeguard for you and for your clients, and then updating it. If you did it 20 years ago, you want to check back in and say, is this still relevant? Do I still keep my client files and my information in this? Have I switched buildings? Would this not be helpful? So really checking back in. That's a good way to set yourself up for success within your practice. We don't want to leave this world having loose ends that have not been tied up, especially if we work with clients like we do. We're out of time. Documentation. Obviously, you always want to have informed consent and release of information. Even if a client doesn't have anybody that they want you to talk to, you still want them to fill out and sign a release of information. They just put not applicable or nothing or kind of a dash through it. You still want them filling that out, signing it, saying, I've signed that you can't talk to anybody. So, okay, well, I'll get to that in a second. Dates of service, fees, things like that, all want to be capturing consistently and continuously through your documentation. What time did the session start? What time did the session end? You want to be documenting if that person called you and canceled. That, especially if you're more forgetful, will help you look back and go, wait, did I charge? When they call you and say, you charged me for the service and I canceled 3 days before, I canceled within that window. You can look back at your documentation. You know, technology now, we can kind of look back at phones and whatnot, but you always want to be documenting. Not necessarily just for legal reasons, but just for smaller instances, maybe with payment and things along those lines. Emails. Some people will say that you should document emails a client sends you. Do you have a secured email system that you're emailing your clients through? Is it HIPAA compliant? If it's not HIPAA compliant, have you told your clients during the informed consent stage that email is not a secure way to contact me? You can email me, but nothing that you say in email will be confirmed confidential. And do you have a disclaimer at the bottom of your signature saying that as well? So those are all things that we kind of forget about. Big hospitals, things like this, you don't really get a say for your signature. Oftentimes they just do it for you. That might be included. But if you're in a private practice or a group practice, you might not think of things like that. Progress notes versus psychotherapy notes. There's a difference. Both can be subpoenaed for court. Progress notes, SOAP notes, that's kind of exactly what it's called, progress notes. How is that person moving towards the goals, the treatment plan that you set with them? If you're not doing progress notes, you don't have a treatment plan, that's something that you need to take a step back and reconsider as well, as there should always be an end goal. This is one of the things I tell someone when they come into my office and I'm sitting down with them for the first time, because our services here are time limited. But I would tell them this if I had my own practice too. Therapy or coaching is meant to get you to no longer be working with me. We're going to spend all this time developing a relationship. We're going to spend all this time getting to the issues and helping you develop skills and overcome these barriers and boundaries that are happening in your life. And the end goal is that you no longer need to come see me because you've got it managed. So if there's no treatment plan, then there's no progress notes. Right? Psychotherapy notes are different. Psychotherapy notes are more of your assessment, your thoughts, things that you might jot down to help you remember their spouse's name or things like that. Typically, they are kept separate. They should be kept separate, but both need to be locked behind 2 layers of locks. So locked in your desk, locked in your office when you're not in the presence of them, or locked in your office, locked in the organization building. And then documenting suicidal, homicidal, and self-injurious behavior. If you don't work with a population that these things come up often, you might not think, oh, I need to be asking about that, or oh, I need to be documenting it. You know, the answer is no. You know, the kids, whoever I'm working with, never says that. But then what happens if one day, unfortunately, a client does complete suicide? And you kind of miss that. The hope is that, that's a terrible situation. We never want that to happen. And the hope is that no ramifications on your end come from that. But it does. You know, it's upsetting. Families oftentimes, or homicidal intent, right? People go out and hurt other people. That's the scope is going to focus in on you. You were treating that person. Did you document it? Documentation, documentation, documentation. It's really important. Even if, well, okay, so this is an example of how you can document. It says, number 1, did the client discuss any of these 3 during the session today? No, you circle no, you move forward. That's it, you don't have to fill anything else out, but you've documented it. If they say yes, then you walk through, you walk through all of these questions. You do a suicidal assessment. That's essentially what this is listed out on here. You want to check for protective measures, and then you want to have an action plan, and then continuation of treatment. What are you going to do next week? What are you going to do? The way we have it set up here is this is the back of our notes, the second side of our notes. On the front, it says follow up from last week. And that section is specifically related to our SI, HI, SIB. Do we need to follow up last week? Did the client say that they were suicidal or homicidal last week? And do we need to follow up with that? Because we always want to follow up. So this is just a checks and balance for us too, especially if you work with a population where a lot of your clients are suffering from this. You know, it might be hard to keep track of. Documentation, it's really important. Excuse me. So moving on, confidentiality. Technology is something that we see more and more in our world, which can make things difficult with confidentiality. I mentioned emails already. Phone calls. I heard a story one time. You might think you're on your cell phone, you're talking to your supervisor or someone in your consultation group, and you know you're not out in like a big public space. You're at a restaurant, and you don't think anyone can hear you, but the person behind you is your client's friend, and here's what you're saying. That's more out in open space. But okay, so the story that I heard was someone was in an airport on the phone with their supervisor having a conversation about a client of theirs. Somehow wires got crossed. I don't understand how any of that works. And their conversation was broadcast through the whole airport system. And everyone heard what they were saying. Regardless of whether it's good or bad, obviously we would hope you'd never be talking poorly about your clients, but that's private, confidential information. And another therapist in the airport, heard that, somehow figured out who the person was, and did contact their licensing board. And they ended up having to go in front of their board to talk about that. That's an example of an unintended issue, right? That person probably had no thought, like, oh yeah, the airport's gonna pick this up and broadcast it, but it happens. So being aware of what we're doing, being mindful of the actions that we're taking and the things that we're saying and the people that are around us is really important. So when you're doing teletherapy, that's coming up, telepsychiatry. You need to be licensed in the state that the client is sitting in, as well as the state that you are in. You also have to have insurance in that state. Where we see issues coming up is, I'm in Texas, I have a client in Maine. They're not happy with me. How do they then, who do they call? Do they call the Maine social work? Or do they call it Texas? Did I break a law in Maine, but not in Texas? So it really puts more responsibility on us as providers to be able to understand not just the laws in our state, but the laws in the states that our clients are in. So that can be a slippery slope, but it's the new wave. It's very convenient. It's really giving care to people who might not have access to it elsewhere, rural areas. So it's just something to think about. Social media is another area that we see coming up. Well, it's not coming up, it's here. Social media is big. You can opt out, you just say, I don't have any social media. A lot of people have that. I'm not very active on my social media. But you know, a lot of people want to have their social media. They don't want to be restricted in their own personal life based on the profession that they're in. So what we see a lot of people doing with Facebook is under their name, they'll have like a disclaimer that says, this is my personal page. I have no affiliations with the organization in which I work. All opinions on this page are my own and are not reflected by the organization. It's a safeguarding measure. You can put it on there, but most organizations have a clause in your hiring letter that says if you do anything online that reflects poorly on you as a staff member of organization, we can let you go. So you're kind of at your own risk with what you're posting online. Obviously, we never want to be posting about clients. Names or no names. Even posting about kind of the work that you're doing can be tricky. You know, would you want to say, oh, I had group tonight, 6 people came, it was great. Okay, well, that seems harmless, right? You didn't say the group name. You know, maybe where you work is on there, someone could figure it out. You didn't put anybody's personal information on there. But John Smith knows that his brother's in that group and comments. You didn't know that it was his brother. Yeah, Sam showed up tonight. I heard it was great. You guys talked about X, Y, and Z. Okay, well, now you didn't technically disclose that, but you've put yourself in a situation where private information is being released. What do? Obviously delete it, but it's happened. It's out there in the Ethernet. It can't be taken down. So again, just things to be aware of. Never posting about things that you're doing at work or with clients. Okay. So HIPAA, privacy rule. So protected health information, obviously that's information that's related to person's treatment, future treatment, or even payment. So I had a dentist bill me one time for my mom's treatment that she didn't pay. So it had her, what she had done, and then the payment. And they kept sending it to me. It was really annoying. So I called them and I said, you're actually breaking HIPAA laws by sending this, because it was my name that they were addressing it to, because I had been a client there. I was like, that's illegal. You know, one, it was more annoying than anything. But two, you know, they pretty quickly stopped sending me letters, because they must not have realized that that was illegal. So the HIPAA privacy rule. So this is where it gets a little tricky. It states that court-ordered subpoenas are sufficient for releasing information. So what's the difference between a court-ordered subpoena? What's the difference between a non-court-ordered subpoena? If you receive a court-ordered subpoena, yes, you can release that information. You always want to seek legal counsel before you do. Never ignore a subpoena. Respond timely, seek legal counsel. If you're a part of a national organization, oftentimes you have free access to legal counsel. And so I know as a member of the NASW, I do. Contact your liability insurance as well. They can provide you some guidance. But a subpoena is really just a command to either appear in court or provide documentation. A court-ordered subpoena, so a subpoena is only a court-ordered subpoena if it is signed by a judge or a federal head. A lawyer can put together a subpoena and send it to you. You have to respond to it, but you do not have to respond with the information that they are requesting. The subpoena might be for you to appear in court, that you would then appear in court if it worked around your schedule. So there's so many ways to get around a subpoena, but yeah, court-ordered has to be signed by a judge, not the judge's clerk. A judge's clerk can sign something, but that's not technically a court-ordered subpoena. So a lawyer can send you, so you want to check, when you get a subpoena, you want to check who it's signed by and what their role is. A subpoena can be written by a lawyer, but then also have a court order attached to it. So don't just go off of the subpoena, you want to look at all the documentation that you're getting, and you want to respond in a timely manner. So steps, compliance with a subpoena. The first thing you want to do, anybody got a guess, is consultation. Ask your supervisor. If you don't know, if you leave here tonight and you forget everything that I just said, reach out to someone and say, hey, I just got a subpoena. What do I do? Do you have any information? Type it in Google. Google will give you a lot of information. It might be confusing, but Google might be able to give you some direction. Call a lawyer. They're going to be able to give you really good advice. They know all of this. They know the legal jargon that's written down on there that might be confusing. They're going to be able to explain that to you. Also, like I said, your insurance company. You want to identify who's issued the subpoena. Is it a court-ordered subpoena, or is it a subpoena sent by a lawyer? contact legal advice. You also want to contact your client. Subpoenas aren't always bad. You know, maybe you had a client from a couple years ago that just couldn't get in touch with you, or for some reason was unable to reach you. They're going through legal proceedings where your documentation will be helpful for them. They might then sign a release of information, and then you can send that information out, and no qualms, right? The client actually wants that information, that public-private health information sent to help benefit them. You can also send the client a copy of the subpoena. If they didn't have their lawyer send it to you, you can say, hey, I just got this subpoena. Do you know what this is? Because they may have some understanding, and they may have, this might be a total shock to them. Especially if they're more peripheral individual in the case or whatever is happening, it might be kind of shocking to them. Like, why would they need that documentation of mine? Respond in a timely manner and document every step. You want to make sure that you're documenting when you call the courthouse, when you call the judge, when you call the lawyer, when you call your client, what you're sending to them. Again, this is just really a safeguarding measure for you to then say, okay, no, I did talk to that person and they said this. Take notes on what they told you. Make sure you're clear. Bug people. Keep calling them. You want to make sure that you're doing the right thing. And if it's that person's role to help you, keep reaching out. So when you're responding to a subpoena, again, if it is a court-ordered subpoena, reach out to the client, see what you can do, but more than likely you will be required to either show up or provide documentation. If you're required to show up and it's not a court-ordered subpoena, you're not able to get around that and you need to show up to the courthouse, you then would sit on the stand and say, all of the information that you've listed in this subpoena is private, confidential information, and I cannot disclose that with you based on my licensure and legal requirements. And then they'll have to go through several loops to get that court order and have things disclosed, right? Like I said, if they sign a release of information, it's not an issue. Before going to court, if it's not a court-ordered subpoena, you can, what is it called? You can send out a letter. I can't remember what it's called. It's not written up there. But to the lawyer or whoever is requesting this information and say, like, what is this for? This information is private. If you can't go at the day and time that's listed on the subpoena because you have clients, you have other previously set schedules, you can get out of it that way. So that's why you want to reach out in a timely manner, because you don't want to not show up, not having told someone, hey, I'm not going to be there. If it is court-ordered, the client, you are required to, like I said, disclose the information or show up to court. You never want to talk outside of the scope of your practice. You never want to give kind of your beliefs, right? You want to talk detailed facts only about the treatment. That's why having progress notes versus therapy notes, psychotherapy notes can come in handy. If you don't keep psychotherapy notes, they're not getting your opinions. So that's not something that can be brought into court. If you have progress notes, all they have is factual evidence of your progress in the treatment and the treatment plan that you are providing with them. So if you go to court, you have to release that information. There's no way around it. You've tried. You then want to request what they call a qualified protective order. And what that is that will require one of two or three things. That the documents that you're providing will be returned to you or to that person and not kept on record anywhere, helping to protect that client's confidential information, or that they'll be destroyed afterwards. So again, even when you do have to provide information that you don't want to, that your client doesn't want you to, that's not the last thing that you can do as a provider to help protect that client's confidentiality. You then want to ask for one of these to have that information given back to you or the client, so it's not sitting on record anywhere. The other thing is a motion to quash. That's something you can do in the beginning stages. If you get a court-ordered subpoena, and the client's like, no, I don't want that information out there. You have to have a legal team or a lawyer write up a motion to quash. And really what that is it's asking the court to disallow the discovery of the information that is requested of you in the subpoena. So they want all of your psychotherapy notes. You can have your lawyer or your client's lawyer file a motion to quash saying this information isn't relevant, it's really going to be damaging, and it's not helpful in the case. If that happens, then you're free. You don't have to provide that information. The court can deny that, and then you would be required to. So that's why keeping legal counsel on hand and having someone identified for you that you can call if a situation like this happens is helpful. So they know your case, they know your practice, they kind of know what's going on with you. Any questions about that? Oh, the last thing. You can get paid if you have to testify. Especially if it's court-ordered, I don't think you can. I'm not for sure on that. But if you have to go and you're providing documentation or talking on the stand willingly and your client wants you to do so, you need to, from the beginning, tell that lawyer and your client your fees, because that's time, a lot of time taken out of your schedule to go do that, and you can bill for that. Any questions about subpoena steps? No? Okay. So, we're done at 8. I'm going to run through these real quick and give you guys time for questions if you have any at the end. So religion or spirituality, this is something that it's a big interest of mine. We don't talk about it much in supervision. You don't hear it in consultation groups, but it's a pillar of hope for a lot of our clients that we're not utilizing. If we're not asking about it in intake, are we really asking all the questions we need to be asking? Even if it's, so we're a faith-based nonprofit. We sit on the Church of St. Martin's Episcopal Church, but we will work with anybody of any faith. We don't discriminate here at all. So someone might come in of a different faith that I don't have as much information about. Asking those questions, being curious, really showing interest in their faith and their religion or their spirituality or whatever they want to term it, is important, just like we would with whatever else is going on in their life. Asking those questions, making sure that we have a good understanding. It really helps to build rapport as well. The reason I put this on here is, I think we are doing a disservice to our clients if we're not asking about faith or religion. Have we covered everything, knowing that faith and religion is not something small, so we see it all over the world, right? Are we ethically doing our job to provide the best care, utilizing all of that strengths from the client if we're not asking about their faith? That might mean that we're in an uncomfortable situation, having to admit that our cultural competence might not be up to par with what we'd like it to be. But it's really going to benefit us in the end, because once you ask those questions, you gain that knowledge, you gain that information, you're able to help other clients. And you can say, I know that now. It's just a learning process. But how do you walk with someone? Not proselytizing. Obviously, your beliefs might be different from their beliefs. Here at the center, we don't proselytize. What the client believes is what the client believes, have a right to self-determination. But where does it come in? Where do we get to take a step in and say, hey, that's not healthy, when it's their faith and their religion? So that can be a tricky line to walk. So the answer is when it's doing harm to them or someone else, right? Obviously, if they're engaging in some religious practice or belief that's clearly hurting a child, we have the responsibility to call, right? But this is, again, it's a pretty tricky line. I had someone tell me once, I think they had this is in a hospital, a Muslim family. The mother was in a lot of pain, and the son had said, and it's one of our tenets that we don't, that someone who suffers, it helps their process into the kingdom, right? It kind of gives them an easier passage into, right? But it also states that if someone is suffering, we should do something to help them. Well, the nurse that was on hand didn't know that, wasn't culturally competent. And so they are like, well, do we not give her pain medicine then? Because the son who is the designated power of attorney, legal power of attorney, what do we do, right? So you sit on these lines with how do you handle this? Hospitals have ethics board consultations. I mean, they have places that they can go to with legal advice to ask these questions, but if you're in private practice, you might not. Hopefully, if you're in private practice and you're not a psychiatrist, you're not prescribing pain medicine, but that's another ethical dilemma that we would really have to talk about. But yeah, asking questions, being non-judgmental, even if you totally disagree with the client, maybe they're like, I can't, I worship this chair right here. It's really done a lot for me. It might seem odd to us, but if that's grounded in reality and that's really how they're developing hope, it's something that you have to kind of look at from a non-judgmental standpoint. And then leadership roles and responsibilities. So we kind of went through this, but clinical supervisory roles and then supervisor roles within an organization. Transparency is really important. Letting your staff and your team know what's going on from an organizational standpoint really helps build that trust. It really helps them feel confident in the services that they're delivering and the decisions that they have control over making. It gives them a boost of confidence to say, hey, I know what to do in this situation, which then helps relieve some of your work as a supervisor because your staff understands why and how things are done. Practicing only where you have skill. If you're in clinical supervision and you have a student or someone post-master's who asks you a question about something that you don't understand, what do? Do you just make something up? No. You say, I'm not really sure. Like, let's look that up. Let's have a conversation. Like, bring a case diagnostic. Let's have this conversation. It's a supervision. It's a consultation group. You might have one of the other students in the group that is in an organization or in a placement that knows how to handle that, right? So you're learning things. So it's a really good practice to be constantly involved in is supervision and consultation. I think I've said that a lot tonight. Referring clients, we want to make sure that we're referring clients when the role that we are in isn't something that's going to benefit them. And then, create a trusting work environment. It's really from the top down. If you have good work-home life balance, your team's going to have good work-home life balance. If you're sending them emails at midnight and you've never told them not to respond to emails at midnight, they're going to be stressed out, which then really affects the delivery of the services that they're able to provide. And it's going to lead to burnout, which we see so often in this field. So what happens if you guys are unsure? Tomorrow, you come into a situation and you're like, I don't know what to do. What should you do? Consultation, yes, consultation. Reach out to people, whether it's legal consult or consults with other mental health care providers or even doctors, psychiatrists, things like that. You really want to reach out and make sure that you're asking the questions, having that checks and balance system in place. There's consultation. And then the benefits of consultation. It removes blinders. You have a sense of connectedness. Oftentimes people working in private practice, you can be lonely. Right? If you have a full caseload and you don't have anybody else in your office but your clients, who are you going to have, kind of normal day-to-day chit-chat conversations with? So having a supervision group or a consultation group, even if you have a hidden ethical dilemma, can really develop a sense of community for you as a provider. National organizations, like I said, often have help with that as well. If you have an issue that's come up, you can contact your national organization and they should be able to give you some guidance. So, and that is it. Thank y'all so much for coming out tonight. Yeah, I really appreciate it. I know it's an hour and a half of your night and we appreciate you being here. If you have any questions, I'm here. Otherwise, have a wonderful night. Thank you.